I want you to imagine a scenario for a second. You are out with friends, you're laughing at a joke, or maybe you just, catch a sudden chill and sneeze.
Right, just a completely normal physiological reflex.
Exactly. But instead of just grabbing a tissue, that sudden cough or sneeze results in an unexpected, uncontrollable leak of urine.
And that alters the entire psychological landscape of your day. I mean, you start subconsciously mapping out bathrooms before you even enter a building.
Yeah, you alter your exercise routines, you change your wardrobe. You basically carry this underlying anxiety into, well, every single social interaction.
And while some people might just dismiss it as, a minor inconvenience of aging or maybe post-pregnancy life, this is actually a daily, highly stressful reality for a staggering portion of the population.
It really is. The epidemiological data we are looking at today shows urinary incontinence afflicts up to 40% of adult women in the U.S. alone.
Wow, 40%.
Yeah, 40%. And stress urinary incontinence, or SUI specifically, accounts for about a third of those cases. So we're talking about a condition driving roughly 200,000 surgical procedures every single year.
And the sheer volume of those surgeries tells a pretty compelling story right there. I mean, the current standard of care is pushing hundreds of thousands of people to the operating table because the conservative therapies just, well, they aren't providing the relief people desperately need.
Which brings us to the actual mission of our deep dive today. We've compiled a massive stack of medical research, clinical trial data, and advanced cellular biology papers to answer a highly specific, cutting-edge question for you.
Right, the big question.
Can localized stem cell or exosome injections actually accelerate the repair of damaged urethral sphincter muscle fibers?
It's such a fascinating pivot because we are looking past the traditional surgical fixes and diving into the microscopic, the molecular mechanisms of regenerative medicine.
But to appreciate why regenerative medicine is so critical here, we really have to look at the mechanics of continence first.
Yeah, it relies heavily on this dynamic physical interplay between suburethral support, which is essentially your pelvic floor architecture, and urethral sphincter coaptation.
Coaptation basically being the ability of the rhabdosphincter muscles to just squeeze tightly and maintain a hermetic seal under sudden pressure.
Right. Think of it like a water balloon. If your bladder is the water balloon, the urethra is the neck, and the sphincter is the mechanism tightly gripping that neck shut.
So when intra-abdominal pressure spikes, like during a cough or a heavy lift, a healthy sphincter actively contracts against that pressure, right? It maintains the seal.
Exactly. But when those striated muscle fibers are damaged or the fascial support degrades over time, the intra-abdominal pressure just simply overpowers the feel, forcing fluid through.
And historically, medicine has approached this mechanical failure with either pharmaceuticals or mechanical interventions.
Yeah, the drug therapies, like duloxetine, for instance, they attempt to increase the pudendal nerve activity to stimulate the sphincter.
But looking at the sources, that has severely limited efficacy, doesn't it?
Yeah. Oh, absolutely. And a super high dropout rate due to adverse systemic effects, which basically leaves surgery as the primary option for severe cases.
Right, most commonly utilizing synthetic surgical mesh to create what they call a mid-urethral sling.
They basically implant a permanent polypropylene mesh hammock under the urethra to artificially recreate that missing suburethral support.
But the literature highlights some pretty devastating complications with that. We see severe foreign body reactions.
Because the immune system recognizes this synthetic polymer and mounts a chronic inflammatory response.
Right. Exactly. And that leads to poor localized tissue healing. In some cases, the tissue degrades so much that the mesh actually erodes into the vaginal wall or the urethra itself.
That sounds horrific.
It is. Plus, there's the risk of postoperative voiding dysfunction, where the artificial support creates too much tension, making it super difficult to empty the bladder normally.
Because you were taking this highly dynamic vascularized system of nerves, striated muscle, and flexible connective tissue and attempting to fix it by permanently embedding an inert, rigid polymer.
It honestly sounds a bit like using stiff duct tape to patch a flexible, expanding garden hose.
That's a perfect way to look at it.
I mean, it might stop the leak temporarily, but the tape doesn't move or expand with the hose under pressure. Eventually, the friction and the rigidity of the tape are going to cause tearing and deeper tissue damage around the repair site.
Right, because the mesh fundamentally doesn't regenerate the damaged rhabdosphincter at all.
Yeah.
It just props up a failing structure.
And that desperate need for a better solution, that inherent limitation, is exactly what drove scientists to look inward, right, at autologous cellular therapies.
Yes, the logic was, If the body constructed this intricate muscular valve in the first place, can we provide the biological raw materials to coax it into rebuilding itself?
Which brings me to a pivotal 2008 clinical trial by Michael Mitterberger that I really want to look closely at. They attempted exactly that.
Ah, yes, the Mitterberger study. This was huge.
They took 20 women suffering from severe SUI and performed a small skeletal muscle biopsy from the left arm.
And then they cultured this tissue in the lab, expanding the progenitor cells into two distinct populations.
Right. Myoblasts, which are the precursors to mature muscle fibers, and fibroblasts, the cells responsible for synthesizing the extracellular matrix and collagen.
The really cool part was the anatomical targeting during the reimplantation phase.
Yeah.
It was highly sophisticated for the time.
They used transurethral ultrasound guidance, didn't they?
They did. They didn't just flood the area with the generic cellular soup. They meticulously injected the fibroblasts into the urethral submucosa to rebuild the structural supportive layer.
And then they injected the myoblasts directly into the rhabdosphincter to regenerate the actual contractile muscle mass.
And the published results are just staggering. At 1 year post-treatment, 18 out of the 20 patients were considered completely cured of their incontinence.
18 out of 20.
Yeah, with the remaining 2 showing significant improvement. And at the 2-year follow-up, 16 of those 18 remained fully cured.
That is wild.
They even backed up these subjective symptom relief with hard urodynamic and electromyography data. They proved increased rhabdosphincter thickness and a massive upregulation in localized muscle contractility.
Okay, I have to pause here. Because I'm looking at an 18 out of 20 cure rate from a study published in 2008. And that raises an immediate red flag for me.
I know exactly what you're going to say.
If autologous stem cells were curing 90% of SUI patients over 15 years ago, why isn't every urologist on the planet doing this today? There has to be a catch. We wouldn't still be doing 200,000 synthetic mesh surgeries a year.
You're right to push back on that. And digging deeper into the sources, the broader clinical data paints a much bleaker picture.
What happened?
Well, the Mariotti meta-analysis reviewed 12 different clinical trials utilizing these autologous stem cell injections. And the mean rate of continence recovery plummeted to just 41%.
Wow, that's a massive drop from 90%.
It is. The discrepancy between a controlled, early-phase trial and broad, multi-center application really highlights the messy reality of live cell therapies.
And there was a 2022 comparative study in our stack too, right?
Yeah, it pitted stem cell injections directly against the traditional surgical midurethral sling. The cellular therapy only achieved a 33% full recovery rate.
Compared to an 80% success rate for the surgical mesh group.
Exactly.
So to understand why live stem cells fail so frequently in the real world, we have to look at the microenvironment of a damaged urethral sphincter.
It is an incredibly hostile environment for fragile, newly transplanted cells.
Right. The area is typically riddled with diffuse injury and ischemia, meaning a lack of adequate blood supply.
And you have to add to that the constant mechanical shear stress from intra-abdominal pressure, plus the highly fibrotic nature of chronic SUI.
So when you inject delicate living progenitor cells into that hypoxic, scarred war zone, a massive percentage of them undergo apoptosis.
They simply die before they even have a chance to engraft, differentiate, and begin the repair process.
It's basically like the cellular workers arrive at the biological construction site, but the working conditions are so toxic and devoid of resources that they perish before pouring a single foundation.
That's a great analogy. And that brutal reality forced a massive pivot in the research. Scientists realized that if the entire cell is too fragile to survive the delivery, maybe they could extract the cell's internal communication system instead.
Enter the exosome.
Exactly. Exosomes represent a total paradigm shift in regenerative medicine. We're moving away from transplanting the factory and instead just delivering the factory's blueprints.
So for our listeners who might not be familiar, what exactly are exosomes?
Like our extracellular vesicles. Essentially nanoscale lipid bilayers secreted by stem cells. We're talking about structures measuring 30 to 150 nanometers in diameter, super tiny.
But for decades, these vesicles were just dismissed as cellular exhaust, right? Like just a way for cells to jettison waste proteins.
Yeah, that was the old thinking.
Yeah.
But the literature now confirms they are actually the primary mechanism for paracrine signaling.
So the stem cells intentionally pack these microscopic vesicles with a highly curated cargo.
Yep, bioactive proteins, lipids, mRNA, and microRNAs. They secrete them into the extracellular space to fundamentally alter the gene expression and behavior of surrounding cells.
So if injecting live stem cells is like dropping a team of construction workers into a hurricane and hoping they build a house, injecting exosomes is like texting the architectural blueprints directly to the local cells that are already surviving there.
Telling them how to rebuild. Yes, exactly.
And that structural difference seems to solve almost every logistical nightmare associated with whole cell therapies.
Oh, absolutely. Because exosomes are cell-free, they lack the major histocompatibility complex molecules that trigger immune rejection.
So you don't have to worry about the lingering risk of maldifferentiation or unchecked cellular proliferation leading to tumor formation.
Right. Plus, their nanoscale lipid structure allows them to effortlessly cross biological barriers, and they're exponentially easier to freeze, store, and transport.
By delivering the paracrine factors directly, we bypass the need for cell engraftment entirely. We are simply delivering the molecular instructions for repair.
And we really should unpack those instructions because the biochemical pathways detailed in the research are phenomenal.
Let's do it. When these exosomes arrive at the damaged sphincter, one of their primary functions is driving M2 macrophage polarization, correct?
Right. Macrophages are highly plastic immune cells. In a damaged sphincter, they predominantly exist in an M1 phenotype, which is pro-inflammatory.
Meaning they secrete cytokines that exacerbate tissue damage and call in more immune cells to fight perceived pathogens.
Exactly. But exosomes effectively reprogram these macrophages, forcing them to transition into the M2 phenotype.
And M2 macrophages are anti-inflammatory and pro-regenerative.
Yes, they shut down the immune assault and begin secreting growth factors that stimulate angiogenesis, which is the formation of new blood vessels.
So you're basically terraforming the hostile microenvironment.
Terraforming is a great word for it.
Yeah.
But the real structural repair relies on the microRNA cargo.
The sources highlight miR-501 as a critical component here.
miR-501 is fascinating. When local cells absorb exosomes enriched with miR-501, it targets and suppresses specific gene pathways that usually inhibit muscle growth.
So it directly accelerates the differentiation of native myoblasts. It forces the surrounding tissue to prioritize building functional striated muscle fibers.
But you can't just build muscle if the area is full of scar tissue, which brings us to miR-381. It addresses the most stubborn hurdle in SUI repair: fibrosis.
Because when the sphincter sustains chronic microtrauma, fibroblasts default to laying down dense collagen crosslinks, right? Scar tissue.
And scar tissue lacks the elasticity and contractility required for sphincter coaptation. It totally ruins the mechanical seal.
But the exosomes utilize miR-381 to actively shut down that scarring process by targeting a very specific metabolic pathway, YAPGLS1-dependent glutaminolysis.
Right, glutaminolysis is essentially the conversion of gluten into cellular energy. Fibroblasts require massive amounts of metabolic energy to continuously synthesize and excrete the heavy collagen proteins that form scar tissue.
I like to think of the YAPGLS1 pathway as this heavy freight train delivering raw fuel to a rogue manufacturing plant that's just churning out stiff, useless scar tissue.
That's a great visual.
When the miR-381 from the exosome binds to the target mRNA, it derails that train. It cuts off the metabolic fuel supply.
And without that energy, the fibroblasts downregulate their collagen production. This halts the progression of fibrosis and leaves the physical space open for the newly stimulated myoblasts to lay down contractile muscle.
Concurrently, the exosome cargo upregulates complex intracellular kinase networks, right? Specifically the PI3K-ACT and ERK pathways.
Yeah, these are essentially the master regulators for cellular survival and proliferation.
So by activating these specific networks, the exosomes actively stimulate the regeneration of peripheral nerve fibers alongside the skeletal muscle.
You aren't just building muscle. You are wiring it back into the central nervous system so it can actually contract on command.
It is a brilliantly orchestrated biochemical cascade. You are simultaneously halting inflammation, starving the fibrotic process, triggering myogenesis, and restoring neural connectivity.
It's elegant.
But looking at the physics of the lower urinary tract, a massive logistical flaw stands out to me.
Oh, the clearance rate.
Yeah. If exosomes are just tiny nanoscale bubbles of liquid, and the urinary sphincter is under constant pressure and movement, how do doctors stop the exosomes from just washing away the second they are injected?
That rapid clearance rate is the Achilles heel of all localized nanoparticle delivery.
Yeah.
I mean, the half-life of naked exosomes in highly vascularized or dynamic tissue is often measured in minutes.
So if you inject a liquid exosome suspension into that highly dynamic muscle bed, Those molecular blueprints are going to be washed out into the systemic circulation or excreted way before they can be internalized by the local cells.
Exactly. To achieve the deep tissue remodeling we were talking about, the local cells need sustained exposure to these microRNAs over days or even weeks.
Which leads us to a fascinating solution developed at the Mayo Clinic using a porcine model.
Right, pigs. They're frequently utilized in urological research because their lower urinary tract anatomy and sphincter pressures closely mimic human physiology.
So the researchers recognized they needed a physical anchor to keep the exosomes in place, and they engineered this specialized hydrogel delivery system.
They isolated a human platelet-derived extracellular vesicle product, which they abbreviate as PP.
Which is essentially a highly concentrated dose of these regenerative exosomes.
Right. And they integrated this PP into a specialized hydrogel matrix composed of collagen 1 and fibrin blue.
The ingenuity here really lies in the thermal properties of this specific hydrogel mixture,
Because at room temperature, the collagen and fibrin remain in a liquid sol state. It flows easily.
which allows surgeons to inject the exosome-loaded mixture precisely into the rhabdosphincter using just a standard fine-gauge needle.
But the moment that liquid matrix hits 37 degrees Celsius, the ambient temperature of the human body, the thermal energy, triggers a rapid conformational change.
The collagen fibrils begin to cross-link and the fibrin polymerizes, so the liquid instantly sets into a firm, highly porous gel.
Under a scanning electron microscope, the researchers actually observed that this thermal polymerization creates an ultrastructural bead on a string pattern.
So the hydrogel effectively weaves a microscopic sticky net directly inside the muscle fascicles, physically trapping the exosomes in place.
And by embedding the exosomes within this cross-link matrix, the researchers achieved critical sustained release.
As the body slowly degrades the biodegradable hydrogel over several weeks, it continuously releases a steady metered dose of the PEE exosomes into the surrounding damaged tissue.
And that sustained exposure completely transformed the outcomes in the porcine model. The histology confirmed profound new skeletal muscle formation and the exact M2 macrophage polarization we discussed earlier.
The sustained release of exosomes successfully induced functional restoration of the external urethral sphincter without the use of a single live stem cell or a rigid piece of synthetic mesh.
It's incredible. And the clinical implications of effectively localized exosome therapy go far beyond stress urinary incontinence.
Oh, for sure. We are looking at a universal mechanism for reversing tissue degradation, which perfectly aligns with the insights coming from longevity organizations like Forever Labs, emphasizing the critical importance of cellular banking.
Because the sources outline a pretty harsh biological reality. Our stem cells, and subsequently the exosomes they produce, undergo cellular senescence as we age.
Their telomeres shorten and their paracrine signaling becomes less potent.
An exosome harvested from a 75-year-old stem cell simply does not possess the same concentrated regenerative microRNA cargo as an exosome harvested from a 30-year-old cell.
The blueprints degrade and fade over decades. This makes the concept of banking autologous biological material, whether it's adipose tissue, bone marrow, or muscle-derived progenitor cells while you are young and relatively healthy, an incredibly strategic move.
It totally redefines how we manage our biological assets.
Right. This completely flips the script on aging. It means we aren't just stuck with the tissue degradation we experience over time. If you bank those potent, youthful cells early, you essentially secure a personalized repair kit.
Decades later, when you face stress, urinary incontinence, or joint degradation, or muscle atrophy, scientists can just thaw those bank cells.
Extract their highly active exosomes and deliver them via a thermosensitive hydrogel to regenerate your failing tissues using your own pristine, youthful blueprints.
It represents a fundamental shift in medical intervention. We are moving from reactive structural patching to proactive biological regeneration.
Yeah.
We're learning to utilize the body's native repair mechanisms at the nanoscale.
To truly grasp the magnitude of this shift, let's look at the journey we've covered today. We started with the sheer mechanical failure of stress urinary incontinence and the severe inflammatory complications of trying to support a dynamic muscle with a rigid synthetic mesh sling.
And then we examined the brilliant, yet ultimately flawed, early attempts at injecting live autologous stem cells.
We saw that while the cells had the capacity to heal, the hostile, hypoxic, and fibrotic microenvironment of a damaged sphincter caused massive cell death before regeneration could even occur.
That failure drove the pivot to exosomes, extracting the molecular instructions rather than delivering the fragile cells themselves.
We explored how cargo like Mir-501 and Mir-381 orchestrate a massive regenerative cascade, polarizing macrophages to reduce inflammation, starving fibrotic fibroblasts by cutting off their glutaminolysis pathways, and triggering the PI3K ACT networks to rebuild muscle and nerve tissue.
And finally, we broke down the physical delivery mechanism, detailing how thermosensitive collagen and fibrin hydrogels polymerize at body temperature to weave a microscopic net, ensuring the sustained, localized release required for true tissue remodeling.
The convergence of bioengineering and cellular signaling we've explored today is remarkable. But before we wrap up this deep dive, I want to leave you with one final provocative concept to consider.
Ooh, I like where this is going.
We focused heavily on autologous therapies and banking your own cells. But if scientists can now precisely identify and isolate the exact microRNAs like Mir-501 that command the body to build sphincter muscle, how far off is a future where we bypass cellular extraction entirely?
Wait, you're talking about fully synthesized exosome therapeutics.
Exactly. Could we soon see off-the-shelf, synthetically manufactured lipid vesicles packed with lab-printed microRNA cocktails designed to regenerate specific tissues?
That would be revolutionary.
Imagine a world where treating stress urinary incontinence or repairing a torn rotator cuff doesn't require surgery or even your own banked cells. It could simply be a routine outpatient injection of a universal synthetic blueprint that commands your local tissue to rebuild itself perfectly.
It fundamentally challenges the limitations of human healing. We're entering an era where medicine acts less like a carpenter fixing a broken frame and more like a software engineer pushing a critical update to the body's operating system.
An era where we don't just patch the damage, we rewrite the local code to erase it. Thank you for joining us on this deep dive into the sources today. It has been a fascinating exploration of the microscopic mechanics of healing. Stay curious, keep exploring, and we will see you next time.